Yeah. So I thought to give a talk on palate surgery, primarily UPPP, and it's a very immense subject, but I'd like to go back and kind of give you an overview so you know where we are and why we're here and what we can do. So some of the goals here to understand how the procedure was developed, and then how to evaluate patients for the UPPP operation, understanding why UPPP sometimes fails, and then understanding the variants of UPPP and how to put them into use. So we'll do a little bit of historical review, talk briefly about goals and metrics, what modifications have been used, and then looking specifically at why UPPP fails, and what are some of our evaluations and methods to look at these things. And then finally, where does the UPPP surgical procedure fit? So you have to understand that pharyngeal collapse occurs at more than one site in the majority of patients. So this will limit the isolated UPPP procedure as a cure for obstructive sleep apnea to a small amount of individuals. And once this was understood, the concept of multi-level surgery was born. And this was spearheaded out in Stanford University in California in the late 80s. And so now the UPPP is performed often in conjunction with other airway procedures, either by itself or in multi-stage fashion. The indications for UPPP are not as relevant when it's part of a multi-level approach. And Michael Friedman in Chicago said that only in his series, only 23.5% of patients were considered acceptable candidates for the UPPP procedure, meaning that 75% needed a multi-level procedure. So just a little review, the Pickwickian syndrome was first described in 1965, and then in 1970, the first sleep center for study of sleep was created, but obstructive sleep apnea as a diagnosis did not exist. But in 1977, the first treatment for OSA was tracheostomy, and this was from France. In 1979, Stanford applied for a grant from the NIH, but it was rejected as not being something that was real or pertinent. 1981, CPAP was first described in Australia, but it was 1986 before the first commercial CPAP became available. So in 1980, Fujita on the right presented the UPPP operation at the American Academy of Otolaryngology. And he got his idea from Ikematsu on the left, who wrote a paper in 1964 in Japanese describing treatment of snoring. And then in 1987, the first surgical text for obstructive sleep apnea was produced just as I was finishing my residency. And these four people are the authors. So this was Fujita or Ikematsu's publication regarding snoring procedure that he developed back in the early 60s. He actually started treating this in the 1950s. Well, Fujita at Henry Ford Hospital in Michigan said that in 1979, I began to explore treatment of patients with severe obstructive sleep apnea, which was just described. And almost all of these patients were heavy snorers, and they were in search of something other than a tracheostomy. So this pioneer published a paper after his presentation at the Academy, and this appeared in 1981. So we started doing UPPP on everybody with obstructive sleep apnea. And it seemed like everybody improved. Snoring got better, sleepiness got better, sleep apnea got better. But what were we really treating and what were we measuring? Early on, they were looking at the apnea index alone, and then the apnea-hypopnea index came into vogue. We looked at saturation. That's, I guess, still under investigation with the desaturation index. And what were we trying to achieve with this operation? Well, he came up with a second paper in 1984, and this looked at 66 consecutive unselected patients in his center. He had a 98% improvement in snoring, and you'll see with UPPP, snoring pretty much resolves. 85% subjective improvement in excessive daytime sleepiness, but looking at the apnea index, 50% success rate. And the non-responders, however, did improve their sleepiness, and their O2 saturation improved as well. And early on, I've had some patients where their apnea hypopnea index was unchanged, but now they weren't having as many apneas, they were more scored as hypopneas. So we actually did something for these folks. But right now it's the AHI that we're all focused on. But is it really the metric? So let's look at the goals and metrics. Robin Cotton said a definition for success is required. And this was early on, so I was junior resident this time. So one thing to note is that the sleep study metrics and sleepiness are not very well correlated. Individuals with severe obstructive sleep apnea, 5% of them are not sleepy at all. So there's a differential susceptibility to sleepiness. And with UPPP, we have improved quality of life, psychomotor vigilance, as reported on in papers looking at those tests. And then driving tests improved uniformly, even if there was no change on the PSG. So these folks didn't fail treatment, but it wasn't reflected on the PSG. And again, keep in mind the goals of treating sleep apnea. We talked about this before. Increase long-term survival and improve quality of life. And again, patients came to us because they wanted a better lifestyle. So these are some available metrics: cardiovascular morbidity, excessive sleepiness, cognitive function, multi-vehicle or motor vehicle accidents, and then some other parameters, snoring, of course, and PSG. And the conclusion is that the proper metric to measure this disease is really unclear, even though we're using AHI right now. And PSG alone doesn't capture all of that, as studies have shown. So it really shouldn't be used exclusively, although it's a good, solid guide. It's not an exclusive point of treatment. So, and then Fujita then developed the classification of type 1, 2, and 3, where he tried to select out patients who would respond to the operation. Well, Scheer in '96 did this landmark paper where he looked at, he did a meta-analysis of all the papers published before then. And in unselected patients, he found success of 41%. And with the Fujita type 1, at best it was 50%, whereas the types 2 and 3, it was abysmal, 5.2%. We all thought at the time it was the base of tongue, and there was no good operation for the base of tongue. But you'll run into folks, primarily the sleep medicine profession, who are not surgeons, who will continue to quote this paper in order to say that the surgical treatment is not indicated, where in fact we have equivalent results when we talk about multi-level surgery to CPAP treatment. So again, UPPP cures only about half the patients, but the literature is misquoted as saying it's unsuccessful, or at best 50% successful, or there are many complications. Really has to be put into its place, and we'll try to do that this evening. So Ed Weaver, who's out in Seattle at the VA, said that if UPPP is primary therapy, then cure is the goal, and CPAP is backup. And if CPAP is primary therapy and fails, then UPPP is backup and improvement is the goal. So the second point is where insurance basically puts us, because they have to fail CPAP before surgery is approved. And then again, what is regular use? 4 hours a night for 5 nights a week. That was based on expert opinion. There was nothing really that brought that into being, and it's still used consistently by insurance and everyone else. So let's just skip this slide here and say that if 50% is not cured, it still helps many patients. And motor vehicle risk, it is improved with UPPP versus CPAP. And then mortality, this was a great paper that Weaver put out, including 20,000 patients, where the people on CPAP at the VA had a 7.1% mortality versus 3.4% for those that had a UPPP done. Because UPPP patients, they don't have to be adherent to CPAP. And CPAP adherence at best is about 50%. So definitions of response has evolved, and I mentioned this early on. And then what is cure? You know, it's considered now that surgery success is good if you can get a 50% reduction in the AHI and below 20%. So what does cure mean? I personally try to get it below 5, but that's my own personal goal. So the better question, as we just talked about, was to what degree is the UPPP effective? And we shouldn't quote the 1980s literature. And we shouldn't expect UPPP by itself to be curative. I think I've beat this dead horse. So now let's do a little procedural retrospective on the UPPP. This was a textbook in 1987. And you see the different methods on the right by Fujita, Simmons, Morin, Fairbanks. I actually preferred the Fairbanks technique, and we'll cover that in a moment. But back in 1987, they said at the time of this writing, snoring has never been quantified, and the understanding of the sleep apnea syndrome is still in its adolescence. I think we're a little further along now, and the technique of Paleoplasty has yet to be standardized. And it still does, even though there are probably half a dozen to dozen different techniques in current use. So this was Ikematsu's technique. He basically made the uvula smaller and took a little tissue out from the soft palate to pull it forward a bit, and then some mucosal resection. So Fujita went a little bit further, became a little bit more aggressive, and pulled the posterior pillars laterally and anteriorly. I think this will get you a great improvement if you consider especially those patients with the very prominent posterior pillars. And the amount of palate removed was based on pillar width. That was kind of a judgment call at the time, because you're actually cutting off palate. And there was a little bit of back and forth at the time about how much to cut off. So Fujita's technique here with the tonsil fossa closed, uvula amputated, and bringing the posterior flap forward and sewing it onto the anterior soft palate so as to avoid a circumferential cicatrix, a kind of a scarring that makes the airway smaller. So the original guidelines were remove as much excess soft palate as possible without jeopardizing the function. And that's where the issue is, isn't it? Because take too much and they'll end up with nasal regurgitation and possibly even nasal voice. So one thing that they looked at was the palatal dimple. So they say, and there's a fold right there called the palatal dimple, and you did not want to cut above that because theoretically that's where the soft palate touches the posterior pharyngeal wall, and if you cut some of that off, then you have problems with swallowing and nasal voice. So again, ideal excision point at the time, but people measured in centimeters too, and thinking that the more you resected, the better results you got. That wasn't always true. Simmons was a proponent of that, and he began resecting a lot because he said you remove too little and the procedure will not work. That was 1980s, and this was kind of what he came up with. And this type of procedure really today shouldn't be done anymore. We have much better techniques. When they compared Simmons and Fujita with the more aggressive resection, This paper said that there wasn't much difference except that you got better success, where in actuality, as it turned out, there were more complications, you would say, with more resection. So the tendency was to be more aggressive. Blair Simmons, he argued against this as being a problem, but his technique is really no longer used. So Fairbanks actually modified the technique, and his was a technique I used for many years because what it did was it maximized the shortening of the palates laterally, and that way you maintain the sphincter action in the midline. Just like when you're taking out adenoid out, you look for passive ansa ridge. That's a real important area, even in adults with palatoplasty. So the first thing that he would do is make a diagonal incision laterally in the soft palate and palate, and now you have an increased mobility of that pillar. And with this, and one reason I did it was it kind of prevented the palatal scar contraction because you broke up the scar by making these cuts. And then he made a mucosal incision anteriorly, and now it was denuded muscle, and what you would do is bring the posterior mucosa anteriorly. And then uvula removal at the time was considered standard. I stopped doing that in the mid-60s. So close the tonsil pockets. It was a single closure at the time. Now I'm using layered closure with chromic for the mucosa and vicryl for the muscle. And left a little uvular bulge. So it resulted in a squared off appearance rather than a curved appearance, and actually prevented stenosis and tethering. But when you were resecting the uvula, you did not want to stretch it, as many of my residents have a tendency to do that right now, because if you do, and then you resect it, the rest of the uvula, the stump, retracts into the soft palate, and so you end up without a uvula. So I teach them to be very gentle and put no stretch on the uvula when you're shortening it. And I always like to leave some uvula behind. So, and the anterior and posterior pillars are really important because taking some of the anterior pillar off allows you space to move the posterior pillars anteriorly and laterally, and it actually lifts the soft palate off the posterior pharyngeal wall and enlarges dimensions both anteriorly and lateral. But if you take off the posterior pillar, what happens when you're sewing things closed is you're pulling the palate posteriorly, and actually it can make the sleep apnea worse. So where does this surgical procedure fit in? Well, some people thought that the region of obstruction was related to severity, that mild to moderate sleep apnea was probably due to the palate, and the moderate to severe was probably base of tongue. But this wasn't accurate and wasn't supported by evidence. Premise number two, mild sleep apnea can have a conservative resection. This was shown not to be true as well. There was no difference between responders and non-responders for mild or severe disease with Aaron Shear's paper. And then Friedman found that severity was not an independent prognostic tool for surgical success. So if somebody has mild sleep apnea, whatever you do, it doesn't mean that it should respond better. So what a lot of folks did, especially out in Stanford in California, they looked at improving the 50% success rate of standalone UPPP. So Riley and Powell combined it with a hyoid suspension or genioglossus advancement, or even with midline glossectomy, and they improved it to about 70%. When they did it with a maxillomandibular advancement, it was in the upper 90s. But this is just to stress, we are not, as otolaryngologists, are not UPPP surgeons. We treat the whole airway. You know, even though today UPPP probably makes up about 75% of surgical treatment for obstructive sleep apnea. That's given way now to the hypoglossal nerve implant. It's taken more of a role. So again, how does UPPP fit in, and what kind of palate surgery is indicated? Well, we've talked about surgery being site-directed, and then using UPPP as an isolated procedure or multi-level procedure. We'll talk about that. So we identify the anatomic abnormalities and characterize the anatomy of the soft palate. So Katzentonis and most others have said you don't want to operate in patients with BMI greater than 40, and I would agree with them for the most part, although that's another story that I'm looking at with a study. Try to get a Mallampati 1 or 2, and then look at the elongated uvula palate. Large tonsils are always a good thing, redundant folds that you can tighten up. And then looking fiberoptically, if the palate nasopharyngeal opening is funnel-shaped and narrowed at the distal aspect, that is by the uvula, this is a good candidate for UPPP. Cephalometric X-rays, which we don't use anymore for the most part. They measured posterior nasal spine to uvular tip. Retrolingual airway has to be greater than 10, because less than 10, actually even less than 6, means you're going to fail. Mandibular to hyoid distance measured on the X-ray is greater than 27 millimeters is a good thing. So you're looking at distal narrowing or even entire retropalatal narrowing. And he stressed that UPPP was a non-specific term, and that the conventional or traditional UPPP enlarges the retropalatal airway. And this includes partial resection of the uvula, which is what I generally do, conservative resection of the palate, and currently I try not to resect any palate. I try to move tissue rather than remove tissue, and then partial resection of the anterior pillars, which I will sometimes do in order to gain an advancement of the posterior pillars. So he uses electrocautery. I'll do that for the tonsil, but I'll use a cold knife for everything else. He used chromic sutures, but people who did a single layer chromic suture closure often found dehiscence. And then tonsils with most of the anterior pillar resected. Currently, I like to leave as much anterior and posterior pillar as possible. I think it makes the closures easier. And oblique incisions, that's what Fairbanks did at the junction of the soft palate and posterior pillar. So this is the so-called conventional traditional UPPP, where the uvula is resected and looks almost like a Simmons palatoplasty with the arch. I personally don't like to see that arch. I don't like to do that arch. What about some modifications? Well, in order to reduce complications such as VPI and also to decrease pain, Powell and Riley at Stanford developed this uvulopalatal flap, which is reversible up to about 2.5 to 3 weeks, and they said had equivalent results to the full UPPP. And they said, don't do it if there's a very thick, heavy palate or uvula. This actually works a lot better in the thin palate with thin uvula. And where they found that cutting cautery had a higher dehiscence rate, so cold knife was better. And they included it in what they called the phase 1 protocol, which is a different story right now. So Todd Huntley introduced this as an office procedure, and the indication was if there was significant webbing of the pillars, basically embedding some of the uvula in the pillar. And the advantage was there was an anterior vector of pulling. It actually pulled things forward, and it prevented stenosis and banding, and you preserve tissue for the most part. And again, less VPI and theoretically reversible. So basically, you lift the uvula up onto the soft palate and you make an outline of what mucosa you're going to remove. And you could extend this laterally as a triangle to get you some anterior pull and elevation. So the mucosa comes off, and then you flip the uvula up and I put deep vicryl sutures, maybe about 4 or 5 of them, and then close the mucosa with chromic without tension. And this actually works because you can get a little bit of extension by making these diagonal cuts laterally. So this procedure we did in the clinic, and I was actually photographing it with a rigid telescope while the resident was doing it. And you got to pick a patient who does not have a hyperactive gag reflex. So sprayed him with a little lidocaine, gave limited lidocaine injection, lifted the uvula up, made our outline, and now you see the number 15 blade demucosalizing the soft palate uvula. And this was in the clinic, and he was quite fine with this. Anything you do to the uvula really hurts. So even though this doesn't look like it would be a painful procedure, it does hurt. Even just cutting off a uvula, people will complain about that, even if you put a couple chromic sutures in the mucosa to cover the muscle. So here you see we're taking the mucosa off the uvular tip, and now putting a this is a chromic that was in the clinic early on, and it did not dehiss, and he complained of pain, but symptoms improved. So this altogether probably took about half an hour, but you have to have good clinic staff and pretty much understand what you're doing so you can just keep moving along. And as you saw, there was not much in the way of bleeding. And so I think we can move on to the next slide here. So why does it fail? Just because it failed doesn't mean it's a bad operation, just poorly applied perhaps. So it's important that you identify the site of obstruction, and effective surgery is directed at this site or sites of obstruction. So the initial Fujita classification assumed type 1 were favorable, but again, 50% success rate. And they found the 2 subgroups, those that responded partially and those that really didn't respond. And the failure was felt to be because UPPP did not address all sites of narrowing or collapse. And back as a resident, we felt this was tongue base, which was partially true. So one of the ways they tried to figure out how it would work was with a procedure called Mueller's maneuver, which is looking with a telescope, endoscope, while you or the patient is holding their nose and they're sniffing in. You're looking to see where the collapse is and how it collapses. And basically all they could find was a negative way to look at it. If there was a lateral wall collapse with Mueller's maneuver, then UPPP was not the best. And if you saw a retrolingual obstruction, that predicted failure. So basically this showed you patients not to operate on for UPPP. And Katzentonis in Washington Hospital Center said that the problem was medial collapse of the lateral wall. Friedman felt it was the tongue base, and then Woodson, Minneapolis, felt it was persistent palatal obstruction. They were all right. So that's why you have to isolate the site of obstruction. And again, isolated UPPP for cure is limited to maybe 20, 25% of patients at best. And so you have multi-level surgery. Friedman developed a staging system in 2002 where he looked at tonsil size and tongue position with the, I think we talked about this, Mallampati's 1 through 4. And stage 1 basically is big tonsils, small tongue, and stage 3 is big tongue, small tonsils. And the success rate with stage 1 was 80% success rate with UPPP. And then stage 3 goes down to 8%. When he added tongue base ablation with radiofrequency, he improved that 8% up to 37%, and then brought the 38% up above 50%. So it showed how treating a minimally invasive retrolingual procedure could improve UPPP success. So what he did is, he said, if specific procedures were added to address the retrolingual success, it goes up. So my memory in the previous slide wasn't as accurate as maybe it should have been. The 8% went to 43%, and the 37% stage 2 went up to 74% with a tongue base ablation. But Blue Cross says tongue base ablation is experimental. And this paper, you can see, is 16 years old. So he tried to hone in on his classification system, expanding the Friedman tongue position 2 into 2A and 2P, depending on how much uvula that you saw. And the 2A basically could fall into a stage 1 treatment, expecting 80% success. So surgical failure, failure of diagnosis, failure of the procedure selected for the anatomy, and maybe failure of application, your applied talent in the particular case. So the key, of course, is correct diagnosis, correct procedure, and then the technique is correctly applied. So Woodson said it wasn't the tongue base, but it was behind the soft palate. And the failures did not get bigger behind the soft palate. I'll show you the imaging here in a moment. And so this led him to develop transpalatal advancement. Here you see on the left, the palate was shortened, but it still had a retropalatal obstruction compared with the one on the right. But I would be afraid with the one on the right that you get VPI with that one. So he characterized soft palate anatomy based on 3 anatomic points. Hard palate, of course, where it ends, the velum, which is the lower portion, and the genu, which is the bend between the hard palate and the velum. And he characterized it as vertical or slit-like when you're looking with a endoscope. Oblique means kind of circular or funnel-shaped. So I have another slide that actually has my pictures in, which I like better, but this has the black and white. So you're looking at the 3 soft palate regions, and the upper is actually how far posterior the hard palate reaches, and then the vertical palate is narrow from top to bottom. The oblique is narrow only at the very bottom, kind of in the funnel shape, and then of course intermediate is in between. And so when the isthmus is proximal, you have a vertical soft palate. When the isthmus is distal, you have that funnel-shaped soft palate, or the oblique character. And this is just an endoscopic view on the left of the distal narrowing. So you can go with a conventional UPPP, consider sphincter expansion palaoplasty. And then here we have proximal narrowing. So that means the hard palate posterior aspect is closer to the posterior pharyngeal wall. And that's when transpalatal advancement is considered. And you can also combine it with a UPPP, but I've not been so bold, and I've just done uvulopalatal flaps with it when it seemed warranted. So here again, we resect the posterior aspect of the hard palate and draw the soft palate anteriorly and place it there with permanent sutures. There's more improvement than a UPPP, he says, and there's some truth to that. And I combine it with a uvulopalatal flap. You can use it as primary or salvage surgery, meaning that somebody has already had a UPPP, you can go ahead and do a transpalatal flap, which I've done on folks, and it adds to their improvement. It actually doesn't hurt as much as you would think, certainly not like a UPPP, and it's certainly less invasive than the bony surgery of a maxillomandibular advancement. So it shows a uvulopalatal flap at the bottom there, but the incision is posteriorly based on the hard palate, and then you resect about 5 to 7 millimeters of hard palate, make a couple drill holes in there, pass sutures through. I don't know why the figure of 8. I've never done it that way. I've just done it straight across. And then he modified it, which I'm not sure why he did. I don't understand that. The propeller incision is sometimes useful. I try not to use it that much. I don't like it so much. But he made a bony island, which you see over on the right. I think that's a lot more work, and I got good results without even doing that, but he felt that that was better for him, and then closing it up. So what about the expansion sphincter pharyngoplasty? Well, remember this diagram that we showed how the soft palate can collapse from anterior to posterior, from concentric collapse in the middle, and then C is lateral to medial collapse, because this will direct you to different types of surgery. And so what we need to do here is we need to tighten the lateral musculature. There's only a few procedures that can do that. A lateral expansion is one. Hyoid suspension can do that, and transpalatal advancement can do that as well. So this is a funnel-shaped obstruction here, and we will see a lateral shaped collapse on the drug-induced sleep endoscopy here in a moment. So in the lateral expansion pharyngoplasty, take out the tonsils, then you identify the ribbon of muscle called well, shoot, I'm blocking at it right now. It'll come in a moment, but it's sitting on the spear constrictor, and it's the palatopharyngeus, and you elevate it from the underlying spear constrictor. And the original operation made diagonal cuts in the mucosa. Now it's a tunneling rather than a full cut. And the suture is placed through the stub of the palatopharyngeus, and it's fastened up near the hook of the hamulus underneath the palatal mucosa. And that's how things close up. Again, I like to leave some uvula behind. So this was a cadaver dissection. This takes about 3 minutes to watch. This was from a course I went to, and they had a live demo. And so I tried to shorten it up. So in this case, we're elevating the mucosa over the tonsillar fossa. And in this particular patient, I can't remember if he had atrophic tonsils or not. You can do it in people who've had tonsillectomies, but doing UPPP in a person with a tonsillectomy is a little bit tougher. You run into scarring. You just made the incision in the soft palate near the hamulus, elevated the mucosa, so now you have a tunnel. And what he's going to do next, he's going to elevate the palatopharyngeus, and you can do that with a right angle. If you get into the superior constrictor, it starts to get kind of bloody, but if you stay above it, you can have a minimally bloodless field. So there's the superior or the palatopharyngeus. I usually incise it about 2/3 of the way down, and really you can't perforate the soft palate mucosa immediately, because that'll wreck what you're trying to do, because it needs to stay attached to that mucosa between the uvula and the pillars, because that's where the pull is exerted. So he's putting through what he calls a tendon stitch, where it basically comes out from the tip of the muscle, and that's what you pull through the tunnel to attach near the malleus, and then you close the mucosa over the top of that. So here he's using a right angle, but I'll often use a tonsil hemostat. It just seems to go a little bit better. I've tried pulling the needle through from the sharp end, from the dull end, and I think if you grasp the mucosa or the suture right near where it's attached to the muscle or to the needle, then you can get the muscle through. And here he's showing it being sutured in the deep palatal tissue near the hamulus. And as you tighten this, it's going to actually pull the corner of the soft palate pillar junction lateral and anterior, so that your vector of motion, see how that happens? And it really is striking when you use a mirror and you're looking at the nasopharyngeal introitus. So final thoughts. Friedman stage 1 goes to UPPP and tonsillectomy. Friedman stage 2 can get lateral expansion, sphincteroplasty or pharyngoplasty. Proximal narrowing gets transpalatal advancement. It's Katzentonis said that. I thought it was great the way he presented it. Complications, I'll have to say that I have been fortunate not to have a permanent velopharyngeal incompetence. I've always tried to be conservative in what I've done, because you can always come back and take more, even though you want to be right on with your judgment. Your judgment is only what it is, judgment. So overall, it's said to have a 2% severe velopharyngeal incompetence. You'll get some early on when there's some muscle swelling and things haven't loosened up yet, but that tends to go away. Nasopharyngeal stenosis, I have to say, I've only seen that once. And when I was in private practice, somebody came to me from Johns Hopkins, and what it sounded like is they had a postoperative infection that wasn't recognized or treated, which, you know, a lot of times patients don't tell you anything until it's maybe a little bit too late to do anything. Dysphagia, you know, I think if you do a good procedure, the dysphagia should be gone for the most part within about 6 weeks or so. Friedman up in Chicago, he does some very extensive palate procedures, and he'll talk about VPI being normal for up to 3 months in some of his procedures. Dryness, I think that is less of an issue if you leave uvula behind. And then loss of taste, whenever you press on the tongue with a retractor for a long time, even tonsillectomy, you can get loss of taste. I've never seen that permanent. And then nasopharyngeal stenosis risk factors. Don't resect the posterior pillars. Leave as much pillar as you possibly can. And then don't undermine pharyngeal mucosa. This was often done to try to get a greater stretching of the tissue, but it was not a good thing to do. Faulty suturing techniques. I go now with the double layer closure. And then other than tonsillectomy, I try to avoid cautery. And then infection, I don't remember seeing any infections with this procedure, and tissue necrosis, I just haven't seen that either. So is ICU care necessary? I put everybody in step down. That's just my approach. In Canada, there were some papers where they looked at mild OSA, even going home the same day, but I'm not that bold. And again, no correlation between complication rate and apnea severity. And then there was increased complications with multi-level procedures. Although as we got better at this seemed to be less of an issue. So in conclusion, we can achieve effectiveness that's comparable to CPAP with multi-level surgery, and compliance with surgery is not required. And for the most part, we can say that obstructive sleep apnea is an anatomic disease, not a neurologic disease, although we do treat physiology with the hypoglossal nerve stimulation implant. And then the surgeon's role should be a major one. And I'll encourage any of you that maybe are interested in this to consider a fellowship. There's only about 230 of us or so that are sleep certified ENTs, and we need more. So success depends on knowledge of anatomy, obstruction usually multi-level, so that doing any one thing is probably not sufficient, and then UPPP is most of what's done out there. Again, nothing is written in stone, but things are still written. So that concludes this lecture. Does anybody have any questions?